Okay, Chapter 7, we're going to be talking about standardized scales, continuing our discussion about measurement methods. This is the third of 4 measurement methods that we'll be talking about. Some of the characteristics of standardized scales. The way they're developed is that you administer the same items to different people, and usually it's 200 or 300 people to determine whether you have good reliability reliability and validity. And you use the same administration scoring procedures for all those 200 people. And again, that ensures partly that maximizes the reliability, so you don't have to worry about inconsistent administration and scoring procedures affecting the reliability of the scores. Generally, standardized scales come with some reliability and validity data. Some come with more than others. And just like many things, there are good standardized scales and there are some not good standardized scales. In terms of what standardized scales can measure, they can measure a myriad of client problems, such as marital satisfaction, depression, anxiety, spirituality, just about anything you can think of, all different aspects of mental health. If you can think of it, probably a standardized scale has been designed to measure it. Dimensions along which standardized scales differ, of course, the concept measure. There are depression scales, anxiety scales, self-esteem scales, etc. They also vary, as I mentioned, as far as their reliability and validity data. Some are more valid than others, or reliable than others. They also vary in the structure. Most scales that we're familiar with are Likert, present items and then ask you along a Likert scale, 1 to 5, 1 to 7, how would you like to respond to that item. However, there are some that take the structure of a checklist. You may be familiar with the life stress scale, where you're asked to check off items that you've experienced over the last year, and that gives you your life scale stress. There's also something called reverse scored items, and we'll be talking about this more later when we talk about a particular scale and how to scale it. I want to show you how to scale a Walmer scale. And basically what reverse scored items are, let's say for a depression scale, I want to show you an example of how reverse scored items are used. On page 193, you have what's called, it's one of the Walmer scales, which we'll talk more extensively about later. But it's on page 193, and this is an example of the generalized contentment scale. And what you'll see there, it's on a scale from the items from 1 to 7, from none of the time being 1 to 7 being all the time. and usually you see that convention. And that's recommended that the higher the anchor, the more of the problem. And so most of your items, I feel, number one, I feel powerless to do anything about my life. I feel blue. I think about ending my life. Or if you reply hi to those items, that indicates that you're depressed. However, there are some items, and you'll see them numbered at the very bottom of the page under where it says copyright 1992 Walter Hudson, and you'll see a list of numbers there: 5, 8, 9, 11, 12, 13, 15, 16, 21, 22, 23, and 24. And those are the items that are reverse scored. So let's look at item 5. It is easy for me to enjoy myself. Okay, well, if you score high on that, you're not depressed. So the purpose of reverse scored items is to throw some items in there because there are some people, I think it's human nature to say, oh, all these items are the same, or asking about the same things, and just start, putting all 5s or all 6s. So you throw in these reverse scored items to sort of force people to read the items, and if somebody's depressed, they don't score high on that item, they score low. It is easy for me to enjoy myself. They may say 2, very rarely. So in order for it to be added in to the other items, you first have to reverse score it. And the way we reverse score items is the way, and there's a formula, but the way I like to think of it, if you'll, just using your paper, just write down one in a vertical row, 1 through 7, and then right next to it, right next to the 1, write 7, and then 6 right next to the 2, and etc. And you can see that then the 2 will map onto the 6. So the reverse scored score for number 5, if you score a 2 on it, is 6. And another trick in reverse scoring items is that you take the highest, the anchor, which is 7, and when you reverse score it, if you have a 2, like for number 5, if we score that 2, then the sum of your original item and your reverse scored item is always 1 over the highest anchor, which is 8 in this case. So 2 plus 6 is 8. So sort of hard for me to explain it without a board, but I hope that was sufficient. And please let me know if you don't understand reverse scored items, and I can go over them in another way. Okay, other dimensions along which standardized scales differ. Some standardized scales have a clinical cutting score. For example, all Walmer scales have clinical cutting scores. And the scale that we just looked at, the generalized contentment scale, has a clinical cutting score of 30. And what that means is that since higher scores mean higher depression, it means that if you score 30 or above, you should be considered you may have clinical level problems. I don't think any social worker or psychologist would make that determination with this scale alone, but it's an indication that you may have may have some serious depression problems. And there are many scales that have these, and many that don't. Unidimensional or multidimensional. What we just looked at was a unidimensional scale. It scored one type of thing. It scored depression, one concept. But there are scales, for example, like the MMPI, which has hundreds of items, I think 300-400 items, which is multidimensional, and it scores a number of different concepts. If you're familiar with the CBCL, that's a multidimensional scale. It's a child behavior checklist, and anything with multiple subscales is considered multiple dimension. For example, the CBCL has a externalizing subscale and an internalizing subscale to measure externalizing problems and internalizing problems. Also, in this chapter, most standardized scales are designed to be self-report scales, so they are designed for the client being the respondent. However, in this book, you'll see that many of the that you'll see a list of scales designed for both practitioners and relevant others. And in addition, standardized scales differ in terms of the time, effort, training needed to administer, score, and interpret. The scales that we're going to use in this class are generally referred to as rapid assessment instruments. And basically they take about they're around 20-25 items, and they can be scored by hand, and they're easy to interpret. And the compendiums at the library that I have at the library are mostly rapid assessment instruments. The ones that aren't are things like the MMPI, the Child Behavior Checklist, where you need a computer to score it, and then the computer will then spit out the scores, and in some cases you'll need quite a bit of training to interpret those scores. Those scores will come with, for example, norms, percentage scores. They'll be normed in terms of age and gender, and if you've heard of psych examiners, they're usually trained, they are trained to administer these more complex scales. So that would probably be a referral. If you needed an MMPI on a person, you'd probably send them to a psych examiner. And finally, they differ on the reading level, and you want to make sure, if you're concerned about how well your client reads, that the reading level of the scale is an appropriate level. For example, all the Walmer scales, and there's I know we were talking a lot about this, but we have a couple of slides on the Walmer scales later, so I'll show you how to get to those. But they're all designed at the 3rd to 5th grade reading level. Usually when a scale is described, for example, in the compendium, it will tell you what reading level it is designed at. Advantages of standardized scales: you have information about reliability and validity, so you can compare different scales, and you can determine whether to use a particular scale based on the reliability and validity data available. They're structured so information is less likely to be missed. For example, this generalized contentment scale that measures depression is structures. It asks about the main components of depression, so you're less likely if to miss any information, as opposed if you did a series, for example, of independent rating scale items and trying to capture all the components of depression. And when we talked about validity, we talked about content validity. I think I need to re-record that lecture, but content validity, if you'll remember from your book, means that it's representative of all the components of that construct. So a standardized scale, you would want to have good content validity. And often they're efficient, simple to use, readily available, inexpensive, and take little time to administer, score, and interpret. And this is, I'm talking about the rapid assessment instruments. It's easy to find these in compendiums of measures. However, if you try to find something on the internet, what you'll quickly find out is people trying to sell their scales, and I would just be wary of those. That they usually are not inexpensive. The Walmer scales are fairly inexpensive and cover most mental health problems that you want to look at. So if I was going to look for standardized scales, I would probably look at these compendium of measures rather than, and I would consider buying these compendiums of measures that are in the library if you're going to do a lot of clinical work, because then you have them and can use them. There are some that you have to pay for, but usually it's pretty inexpensive. And there are some scales, such as the CESD, I can show you later, that are in the public domain. So I'll try to remember to show you that and put that scale on D2L. Cautions in using standardized scales: just because something says they're measuring something, for example, social anxiety, doesn't mean they have content validity, doesn't mean that they're actually measuring the concept suggested by the scale name. So it's very important that you as a clinician look at the individual items, not assume that the scale measures what it says it's going to measure, and you look at the individual items and make a determination that it actually measures what it says it's going to measure. Different measures of the same concept may not be equivalent. For example, there are some depression inventories that I've run into that are for inpatient use only. And this would be very different than a generalized contentment scale or a Beck depression inventory scale that can be used with general populations. So you just have to, and then also all depression scales are not equivalent. So when you're using a scale, again, the compendium usually tells you the purpose of the scale, and you just want to pay attention to that. Just because it's a depression inventory doesn't mean that it's equivalent to any other depression inventory or other depression inventories. Sometimes there's limited information about reliability and validity, and this should be an indication that either perhaps it's a new scale, it hasn't been tested, or maybe that it's not a good scale. If there's not a lot, if there's not information about reliability and validity, then I would probably consider not using it, because there are just so many good scales out there. You know, the exceptions I would make is if there aren't a lot of scales out there for a particular thing that you want to measure, then use it, but use it with caution. And you always want to have something, if you're using a scale that you're unsure about the reliability and validity, you want to design maybe some other measures so that you can compare it with, do some concurrent validity with. We'll talk about the different types of validity to look at. And finally, concepts as measured may not be completely relevant to individual clients, and that's why we talked about the individualized rating scales, because those can be tailored to individual client needs. So you may have an anxiety scale that doesn't measure, just a generalized anxiety scale that doesn't really tap in to the specific type of anxiety, the when and where your client feels anxious. It may not tap into that. So again, you want to just be a cautious user of these things. In administering standardized scales, and a lot of this is common sense, but it's worth noting, you of course want to discuss confidentiality issues, just as you do whenever you're working with clients. And you want to discuss, if you're collecting data, what happens to that data, how it's protected, under what circumstances, homicidal, suicidal ideation, or in cases of suspected child abuse, when that data might not be confidential. The second point is important. Sounds simple. Present with confidence. If you're using the generalized contentment scale, you just graduated, and you're using the generalized contentment scale for the first time, your client should, you don't want to say, this is the first time I've used this, I don't know if it's going to work, but let's give it a try. If you're going to use something, use the client's time and energy to do it, and your own time and energy. You need to present that with confidence that this is something that's important, that is essential to helping your client and monitoring their progress. So present, just sort of that term, fake it until you make it, even if it's only the first or second time that you've used a scale, you still want to present it with confidence. Discuss the importance of accuracy. Standardized scales can be, anybody, I usually say anybody in this room, anybody that's hearing my voice, I guess, can fake out a standardized scale, can make themselves look better or can make themselves look worse. And so it's important to stress accuracy, and that there are no right or wrong answers, and that we just want to get an accurate picture of your condition so that we can help you and we can accurately monitor your progress. Of course, explain the relevance of the measure just as you would explain the relevance of any intervention that you're doing, and how the measure relates to the overall treatment plan and what you're doing. They shouldn't come away with, why am I, filling out all these forms, They should understand how it relates. You should share the data with them on a regular basis, if not a weekly basis, a regular basis. You want to provide clear instructions on a standardized scales. Don't rush them, and answer questions. You never want to interpret an item if you at all can help it. If they don't understand what a word means, then sometimes you get in a situation where you have to define a word for somebody, and suggest that you go to if you can't find a word, a good definition. If you can't think of a good definition, go to a dictionary and get a good definition that's not biased in any way. Because if you start changing the meaning of the items, then you start changing the validity and the reliability of the scales. Take care in how you respond. You don't want, after a client gives you a depression inventory, say, oh, you did really well this week, or, oh, I can see you had a rough week this week, because that sets up, again, sets them up. We talked about the importance of accuracy, and we want to create an environment where there are no right or wrong answers. And sometimes how you respond can be very powerful. You don't realize it sometimes, but you're in a powerful position, and they sometimes want to please you. So you really have to take care in how you respond, because it may alter their answers the next time they take the scale. You want, in terms of diversity, you want to be sensitive to educational, social, and cultural background. Unfortunately, most probably, standardized scales are developed not using diverse populations. So you want to be aware of that. You want to be aware of what populations were used. You want to be sensitive to the social and cultural background of your client, and sometimes you can just do this by reading the items and reading the items with the client, and making sure that I gave you the example, I think, that we took our fostering instrument up to Alaska, a colleague of mine did, and I noticed on the generalized contentment scale, item number 2 is I feel blue. Well, in Alaska, the term blue doesn't mean depressed. So you want to make sure, if you're working with diverse populations, that the language in these scales doesn't mean something else, or it may be just void of meaning. And that's part of answering a client's questions. And you might even say, these scales were not developed on diverse populations. So if there is something, if there are some questions, if there's a question on the scale that you don't understand, that or that you think means something different in your culture or doesn't mean anything in your culture, please let me know. And probably the best thing to do in those cases is to skip that item. Don't even answer it and substitute it. We'll talk about dealing with missing data. Um, but generally, if you skip an item, you then will substitute the mean value of all the other items. That's usually how I would deal with it, so that you don't have any missing data. Because if it's a scale that you just total up the items, if that's how you handle it, the Walmer scales are developed to consider missing data. But if you're given instructions on how to score the data, and it's just add up the items, then you want to make sure that you just don't give that one a 0, because that's going to throw up your score. So if you have to skip an item and the means of scoring the item is just to total the number of items, just give that, calculate the mean of all the other items and either substitute either the mean or the median of the rest of the items. Who should complete standardized scales? You know, we've talked about the advantages and disadvantages with different sources. We're not going to go over that again, but I did want to point out in this chapter that there are lists. I'm going to pause this. If you look in your book on page 199, there are some examples of standardized scales for practitioners. And on page, page 202, there are some examples of standardized scales for relevant others. So, like I said before, usually standardized scales are self-report data, but there are some scales, especially for children, that parents, relevant others have to, whether it's teachers or a parent, have to fill out. And if you'll also know notice in the chapter, you have they also give you the GAF measure. I believe that's it says reprinted with permission from the Diagnostic and Statistical Manual of Disorders. So I guess the GAF is in the DSM, and there's of course, a version of that for adults and then children. Where to complete standardized scales, and I feel like being repetitive, but it's on purpose because I really want to nail in some of these. Maybe nail is not the right term, but I want to just stress some points. Where to complete, it really doesn't matter. You could even do these over, home or your office. You could do them over the phone, sometimes on a computer. But the big thing is that you want to be consistent. Don't do it in the home one week and the office the next week. You always want to do it the same place and at the same time if possible, if you're doing it on a weekly or daily basis, which you should be. When and how often to complete the standardized scales. I mentioned on the individualized rating scales, the goal should be to complete those on a daily basis. In terms of standardized scales, because of test and retest, and also I would consider it burdensome um, force clients to complete standardized scales on a daily basis. In general, you want to complete them once a week. So weekly should be your goal for completing standardized scales. So it's frequently enough to detect important changes, but then not so frequently that it's burdensome. And again, pre-designated times and places. Weekly, Monday afternoon or Monday evening, and those pre-designated times and places should be, of course, representative, and so it captures what you want to capture. So if you know the client is, uh, you don't want to catch a client when they're, maybe Friday afternoons isn't a great time, or Monday mornings is a great time. Maybe Wednesday after work is a better time, where you want to catch depression when it's more representative. It's not extreme in any direction. Okay, Hudson scales, and mention there that a lot of them are listed on pages 188 to 190 in table 7.2. There's also a internet site that gives you some directions on using these. And I'm going to pause this and bring up what's on the text on the CD with your book, what came with that. And I think I put that on your on the content page of D2L, but let me pause and bring. Okay, here's what's on your on D2L, I believe, in the content area. If not, it can be found on the CD. And it gives you some examples of the scales. This is hopefully we can see these. I have to, so you can the software will work. I have to put this in a small window, but you can see the number of, and these aren't all the Walmir scales, but the authors have elected to put these on the CD so that they'll be available to you. But again, generalized contentment scale measures depression. You've got a measure of self-esteem, clinical stress, which is different than anxiety. You want to find about that. Alcohol involvement, peer relations, marital satisfaction, sexual satisfaction, partner abuse scale. Again, some of these you would want to stress the accuracy of the client. If somebody's court ordered, it's probably going to be hard to collect data on alcohol use. And here's the generalized, I think this is the generalized contentment scale, yeah. Kind of small, but it's in your book, and always at the bottom you'll see a list of the reverse scored items. Okay? I just want to show you that. Walmir scales, and somebody asked me in the other section, well, what is Walmir? Well, Walmir, Walter Hudson, who died about 5 or 6 years ago, really dedicated his career. He was a professor in social work at FSU, and he really dedicated his life in putting these scales together and ensuring they had good reliability and validity, and putting the website together. And he received quite a bit of help from his wife, and his wife's name was Mira, so that's where Mira And so that's where the name came from. Wall from Walter and Mir from Mira. So that's where the usually called Walmer scales. Sometimes they're called Hudson scales. The Walmer scales are designed to evaluate changes in magnitude of client problems through repeated administrations. They're designed to be used weekly. They're very inexpensive and easily accessible. They're also have been developed and designed by a social worker. They're easy to learn how to use, and they have excellent reliability and validity. They're also easy to administer, interpret, complete, and score. They fit into that category of rapid assessment instruments. In general, they take 3 to 5 minutes to complete and score. Most of them are around 25 items. All of them are scored the same way, and I'm going to attempt to do that without a board. And all are interpreted the same way, and by that I mean the higher the score, the higher the problem is. Okay, they were all are written on a 3rd to 5th grade reading level, so they can be widely used with adult populations. Again, higher scores indicate more of a problem. And in terms of interpretation, most of them have a cutting score of 30, indicating that a score greater than 30 indicates a clinically significant problem. And as I said before, you certainly want not to use the scale alone to determine that, but your own clinical judgment and perhaps other measures. They all have what's called a standard error of measure, and it's equal to 5. And what this means is it's kind of like a margin of error. Like in elections, you have a margin of error. If you have one, like say McCain in the Tennessee primary got 50% of the vote, and Obama got 40%, Nader, let's say, got 8%. Those numbers are not right, are off. But if you had a margin of error of at the bottom, if it said plus or minus 3, then you would know that the real measure, because these are based on exit polls, that McCain's percentage would be 50 plus or minus 3, which would be 47 to 53, and then 40, Obama would be 37 to 43. And so in that case, that you would project McCain as the winner of the Tennessee primary, because those ranges do not overlap. So that's using a standard error measure, it's similar to a standard error measure is very similar to a margin of error, that you see used in elections that we all understand, or most of us understand. And then in addition to an increase or decrease of less than or equal to 5 points may be due to measurement error. So 30, this clinical cutting score, you want to use that you would be 30 plus or minus 5. So really, when we're talking about a clinically significant problem, if you use the standard error measure, it would be a range of 25 to 35 that would indicate possibly indicate a clinically significant problem. If you worked with a client and their first score was a 45 and their ending score was a 25, then you would add those standard error measure bands, if you will, plus or minus 5, to determine whether or not that there had been significant change between the baseline and the intervention. So that's how you use standard errors of measure. Restrictions on using Hudson scales: should not be used with children under 12 or those with cognitive impairment, and because they're self-report scales, they shouldn't be used when social worker is in a position to give or withhold social sanctions, such as in a case where you're in DCS and you're in a position to determine whether a mother gets a child back, or a court-ordered drug treatment, and that kind of thing. Other standardized scales I mentioned for the practitioner, relevant other. Again, most standardized scales are self-report, and then the actually this shouldn't be. Oh yeah, that's right. It should be gas scales are on table 7, 9, and 7, 10. In addition to the compendium of measures that are in the library for you to use, there's an appendix at the end of chapter 7 that lists other compendiums of measure. And again, if you're going to be in clinical practice, it might be worthwhile picking up one of these. I recommend the Corcoran and Fisher. This is the 2000 version. I think we have the 2007 in the library, or 2000. I think it's the 2007 version, and that's the one that's in reserve in the library. And then there are some internet resources, but again, whenever you're using internet resources, you just want to be careful. You want to make sure that they've been tested, they have adequate reliability and validity data, and you want to make sure that, anybody can slap a bunch of items together and call it a scale. So a valid scale should have associated with it some type of journal publication, peer-reviewed journal publication. That's usually an indication that, yeah, okay, this scale's for real. It's not just a scale, put together by somebody, or a Cosmo scale, or anyway, I think that's all I want to say about that. And I just referenced this. If you want to put together your own scale, it's not an easy thing to do. It may look very easy, but it's very technical, and you must determine the reliability and validity, all those different types of reliability and validity as described in chapter 2. You must collaborate with persons with measurement experience. I'm a pretty good researcher, but I would need to collaborate with somebody that has more statistical experience than I have. You have to use statistical software, of course. We have that in our labs. We use that, SPSS. And then in order to do that, you have to recruit subjects. If you're developing for example, a 30-item scale, at minimum it would require 150 people, and ideally 10 subjects which would be 300 subjects, to establish the psychometrics of the scale. And by the psychometrics of the scale, I simply mean the reliability and validity of the scale. And at the end of the next chapter, we'll discuss other issues of reliability after covering all the other measurement issues, and that's the end of chapter 7. So I'm going to stop this and